Hi, good evening. I would like to thank the Oncology Club of Bangladesh and the organizing committee for inviting me here today to speak to you about metastatic CRPC and what the current standard of care is. I'm Ravi Kanesvaran. I'm currently the Deputy Head and Senior Consultant at the National Cancer Centre, Singapore. And my area of specialty is in GU Oncology. So today, I'm grateful for this opportunity to share with you some of the latest data and my experience. These are my disclosures. In this talk of about 20 minutes, I'll talk about guidelines, standards of care in metastatic CRPC, sequencing, and the near future, what is right on the horizon in terms of treatment options. So this is the NCCN guideline. As you can see here, there are many options available for the treatment of metastatic CRPC. If you start with novel hormonal agents like ABI, ENZA, or APA in the first line, apalutamide, then there are many options to choose in the second line, like chemo, like docetaxel. Then subsequently, you also have third line options. So a lot of things would depend on patients' comfort level, access to these drugs, cost, tolerability. So apart from just efficacy, there's so many other factors to consider. And right at the end, I'll summarize, giving some ideas on how you can choose the appropriate drug for the appropriate period of time, because there's so many options available. Some of these drugs are relatively new. As you can see here, there are drugs like olaparib and rucaparib, which are listed here as well. So I'll go through some of this data, and then I'll summarize right at the end. So the treatment landscape up to the end of last year is somewhat complicated because it depends on which phase of the disease you are. Earlier, I had a discussion on non-metastatic CRPC, which is up here. Then subsequently, there's also metastatic hormone-sensitive prostate cancer, which I didn't discuss. And now I'll zero in on metastatic castrate-resistant prostate cancer. So you can see some of these drugs overlap. So if you had used the drug before, you probably can't use the drug again because there's resistance. So the choice of options right here at CRPC really is dependent on what has been used before in either M0 CRPC or MS hormone-sensitive HSPC. Now, these are the classical trials. Classical, I say, because many of these trials are more than a decade old. So firstly, the treatment paradigm in metastatic prostate cancer changed tremendously in 2004 when docetaxel came into the picture. So it was chemotherapy. Prior to that, no treatment had shown overall survival benefit. Docetaxel was then compared with mitoxantrone, and it was shown to have a significant, about nearly 3-month additional survival benefit. At that point in time, MCRPC patients were surviving about 1.5 years. So you see 19.2 versus 6.3 months, 16.3 months for TAX327. Subsequently, a slew of drugs have come into the picture. They are lumped together as novel hormonal agents. Some call them secondary hormonal, but they are more than just the first generation secondary hormonal because all these drugs have been shown to prolong survival. So firstly, they came after the use of docetaxel. So you can see here, Cougar 301, and the survival is obviously shorter than what you saw in docetaxel because it's after docetaxel. So it's 14.8 months. ENZA as well, in the AFFIRM trial. And subsequently, they were pushed in front of docetaxel. And then after that, when these drugs were brought forward, you're looking at nearly 3 years of survival, 35.3 in Cougar 302. There are drugs like Sipuleucel-T, which I highlight here in the IMPACT trial, which are not available in Asia. And now not so commonly used in the rest of the, in US as well, only a few centers use it. So based on all those studies, I now zoom into what has come into the picture of late. The first of these studies is called the PROfound study. So these were MCRPC patients who had progressed on a novel hormonal agent like ABI or ENZA, and they needed to have one of these qualifying genes which have a direct or indirect role in homologous repair recombination. So patients who had these genes were randomized, were then divided into 2 cohorts. Cohort A, when they harbored BRCA1, BRCA2 or ATM, and cohort B, another 12 other alterations. And after that, They were then randomized to receive either olaparib or physician's choice. So what were the options given to physicians? They could choose the alternative drug. So if they use Abi before, they can choose Enza. If they had Enza before, they can choose Abi. And the primary endpoint was radiographic progression-free survival with a number of key secondary endpoints, including RPFS in both the cohorts, because the primary endpoint was just cohort A, and also objective responses, time to pain progression, and overall survival. This study was presented first at ESMO 2019. And at that point in time, in ESMO 2019, the data showed that the study had met the primary endpoint of RPFS for patients with BRCA1, BRCA2, or ATM mutations, cohort A. As you can see here, patients in cohort A had a median RPFS of 7.39 months, or nearly 7.5 months, versus 3.5 months for physician's choice, a near doubling of the radiographic progression-free survival. Now, when you look at subgroup analysis, nearly all groups of patients benefit. It didn't matter whether they had previous taxane or no previous taxane, because a proportion of these patients actually did not have taxane before. And it didn't matter whether they had measurable or no measurable disease, they still benefited. And probably the group that had least benefit was those with ECOG2, but there were not many of them. And as you can see here, the 95 confidence interval is pretty wide. Others included age, which didn't really factor in. Whether you're older or younger, you benefited from it. It didn't matter which geographical location you were from as well, and what your baseline PSA was. At that point in time, in ESMO, which was September 2019, about a year and a half ago, the interim overall survival was not mature yet. The data wasn't mature, but there were signals that olaparib was superior. So for cohort A, as I mentioned, these were patients who had BRCA1, BRCA2, or ATM. There was a significant survival benefit of 18.5 months versus 15.1 months. Now, when you included all comers, there was also a benefit of 17.5 versus 14.6. However, like as I mentioned, there were insufficient events at that point in time for this to be significant. So they needed to wait for further follow-up. And that happened with a publication, most quite recently, and also presentation at ESMO 2020. So this was an online ESMO, as you can recall last year. And olaparib did improve OS in cohort A. So that was the only group that benefited, or at least in terms of overall survival. So patients with BRCA1, BRCA2, or ATM who had olaparib had a survival of 19.91 months versus 14.7. That's a reduction in mortality of 31%, which is significant. So this drug went on to get FDA approval for use in cohort A. For European Medicines Agency, however, they looked at the benefit when they broke down by group. And BRCA1 and BRCA2 patients seem to benefit more than ATM. So the European Medicines Agency only approved this for patients with BRCA1 and BRCA2 only, and not for ATM. Now I'll move on to sequencing. So we know from a number of previous retrospective studies that if you were to use Abi followed by Enza or Enza followed by Abi, the response to the second drug is quite dismal. However, a lot of us still use this because some of patients are A, not fit for chemo, so that leaves them no option, or B, not keen for chemo. So there are many patients who do not want chemo and they want to bide their time with more hormonal agents until they don't have a choice. Either way, the design of this study was to answer the question of which should we start first. I think clearly it didn't matter which you started and which you went to, because if you look at this Kaplan-Meier curve on the right-hand side, extreme right-hand side, there was no difference in overall survival, whether you started Abi followed by Enza or Enza followed by Abi. What you do know, however, is their response rates are not so good. And we know that from prior studies as well, the retrospective studies. However, it seemed like if you started with Abi first, Enza could salvage more of those patients. But at the end of the day, like I said, it didn't really matter because overall survival was the same. So that leads on to this CARD study, because we know that hormonal versus followed by hormonal is probably not good or not ideal. So CARD was designed to answer that question. So these were all patients who had docetaxel before and one hormonal agent. So we're looking at the third line. What should we do? should we get on to another hormonal agent or should we switch to cabazitaxel? So this was a relatively large phase 3 design, open label because patients knew whether they were going to get chemo or hormonal. And patients were randomized to cabazitaxel at 25 milligram per meter squared. We now know that probably 20 milligram per meter squared is sufficient based on the Fastana study. So I think this, obviously this trial design was done earlier. So they used the prior dose, which was 25 milligram per meter squared, and they were compared to either ABI or ENZA, depending on what you had used before. So that's why the word alternative ARTA. So novel hormonal agents are also known as androgen receptor targeting agents. So that's why it's shortened to ARTA. The primary endpoints were radiographic progression-free survival, with key secondary endpoints of overall survival, PFS, PSA response, and tumor response. They also looked at other secondary endpoints like response to symptomatic skeletal event, safety, health-related quality of life, and biomarkers. So I zero in to the primary endpoint, which was radiographic progression-free survival. As you can see here, there was a significant RPFS favoring the use of cabazitaxel. Clearly, there's a separation of curves in the Kaplan-Meier curves, and you can see here the median RPFS was 8 months versus 3.7, doubling of the RPFS. OS was much better as well, favoring cabazitaxel, 13.6 months versus 11 months. So this answers the question that about sequencing. So if you have used an ARTA or NHA before, you should actually be getting on the second line chemo rather than switching over to the other NHA or the alternative NHA. Now, what's on the horizon? So it looks like we are moving down the path of personalized medicine. You saw that with the BRCA or HRR studies using olaparib. Now, this was another one looking at tumors with PTEN loss. And about half of metastatic prostate cancer, castrate-resistant prostate cancer patients actually have PTEN loss. So they stratified these patients by tumor PTEN loss by immunohistochemistry, prior docetaxel, progression by PSA only, and these patients were randomized to receive either ipatasertib, which is an AKT inhibitor, versus placebo plus abiraterone. So ipatasertib was given together with ABI. And the primary endpoint was radiographically assessed progression-free survival in both the intention to treat arm and the PTEN loss arm, but PTEN loss by IHC. Secondary endpoints, they looked at PTEN loss by NGS. Unfortunately for this study, there was no significant difference in RPFS for the intention to treat population. All comers, didn't matter whether they had PTEN loss or not. As you can see here, the stratified hazard ratio is 0.84, but the p-value was not significant. However, when they looked at PTEN loss by IHC, there was some benefit noted. As you can see here, the stratified hazard ratio is 0.77. Specifically for the group where they checked it by NGS, there was clearly a benefit, RPFS benefit, which I've not highlighted in these particular curves. Nevertheless, this trial study was not significant. The data wasn't significant enough to change practice. So ipatasertib is still not on the horizon yet. I think we have to wait for more mature data, and perhaps PTEN loss by NGS may be the way forward in time to come. How about the future? Is 2 better than 1? So this study was presented 2 years ago at ASCO, looking at combining ENZA plus ABI. And clearly there was no difference. As you can see here, the curve on top, ENZA plus ABI, was no better than just ENZA alone. Hence, that may not be the way forward, but companies are still looking at this approach. So ARN 509 is apalutamide. So ENZA is now being combined with apalutamide, which is similar class as enzalutamide. And we are hopefully going to get the data for this study pretty soon. So this will definitively answer the question whether an AR antagonist like apalutamide should be combined with abiraterone acetate, and will there be a survival benefit? We already know the answer is no with enzalutamide, but maybe it's going to be different from apalutamide. We don't know yet. So now I'm coming back to my starting slide, which is systemic treatment. So as I pointed out, there's so many options available. As you can see here, I didn't discuss some of them because they were considered historical trials. Many of you know the data behind it. For example, for radium-223 from the Alsimca study. So I highlighted the new things like olaparib. Checkpoint inhibitors are still not on the horizon yet, or immunotherapy. The issue with that is that there's only one particular study where immunotherapy was used in a variety of tumor types for patients who were MSI high. Unfortunately, there was only one prostate cancer patient in the study. So although pembrolizumab has received tumor agnostic approval by FDA for use in multiple tumor types, including prostate cancer, the MSI high population, for one, is very, very small in MCRPC, only about 2 to 4%. And the other thing is there was only one prostate cancer patient in that study. So it didn't really change standard of care. Now, this I want to highlight, which is patient profile, choice of treatment. So these are factors I would consider when deciding how to treat MCRPC patients at this point in time. So first thing is patient profile, or looking at their comorbidities, their performance status. So patients can be divided into whether they're chemo fit or chemo unfit. So if they're chemo unfit, your answer is pretty clear. If they're fit for hormonal therapy, they should get hormonal therapy like Abi, Enza, apalutamide. Now, next, in the CRPC segment, as you can see here, treatment will depend on what was used in the HSPC segment. So if you've used some of these drugs like Apa or Enza, then you'll have to move on to chemo here, because moving on to another ARTA probably doesn't make sense with relatively dismal responses. So that's my third point, which is not to sequence NHA after NHA. And my last point is, if patient is fit for chemo, try to use it as early as you can, because there are factors that may drive you to use chemo even earlier. So these are patients who have neuroendocrine features, small cell of the prostate, but there are other features as well, like lytic bone mets, low PSA versus high disease burden, because these are probably not PSA secretors. So these are some of the factors that you may want to consider when deciding when to use chemo. But in many situations, if patient is fit, you should try to use it early rather than late, because they may miss the boat. And we know for a fact that the more drugs that we use in that sequence, the longer we can prolong patient survival. So these are the factors I would use to determine what drugs to choose, when to choose them, and how to use them in metastatic castrate-resistant prostate cancer patients. Now, what else can we do when contemporary management fails? So in my center, we have opportunities for clinical trials. So we have a number of trials ongoing in prostate cancer. There's one currently looking at chemotherapy plus immunotherapy. There's another one looking at a new combination for patients who are not keen for chemotherapy of targeted therapy, which is cabozantinib plus atezolizumab. And there are other things that we can do to maybe select certain patients for some drugs like pembrolizumab, for example, patients who are MSI high, MMR deficient, TMB high. And what's there on the horizon, and this is a treatment that we have started using here in Singapore while waiting for more concrete data, and that data is going to probably be presented exactly this weekend, because this weekend is ASCO GU. As you're listening to this, you probably know that ASCO GU has come up with quite a bit of data. So the VISION study may highlight this. So if you have access to ASCO GU, you may want to check it out to see whether this trial was positive. So in summary, there are many approved therapies in the treatment of MCRPC. There's detailed data available on the best sequence. CART provides evidence for cabazitaxel in a similar setting as above. Genomic testing is coming to the forefront. So with PROfound, you definitely have to do at least the HRD or HRR mutations to select patients that are appropriate for this therapy. And there are new therapies like PSMA, lutetium, immune checkpoint inhibitors still under investigation, and we should get some insight into that soon. With that, I thank you very much.